So, ladies and gentlemen, dear Chairman, thank you for the invitation. And first of all, I want to apologize on behalf of Professor Schmitto, who is not able to come here, and I am representing him on an ad hoc basis. So I want to give you an overview about the minimal invasive procedure in Hannover, and in addition to this, I want to present you a very interesting, challenging case we performed last year. So since the numbers of LVAD implantations are worldwide continuously increasing, it is clear that the minimal invasive implantation also increases. But this is not the only reason for the rise. When you look at this chart, you see in 2009 we started our minimal invasive LVAD program in Hannover, and the first 2 years we only performed a few cases. And in this time we tried to gain some experiences, and we try to make our learning curve. And after 2 years or 3 years, then the numbers of minimal invasive procedures, they were disproportionately rising. So this was first because it's a safe and a reliable and advantageous procedure. So when I look at this slide, it's somehow for me that I look in the past, where due to the big-sized first and second generation assist devices, the preferential implantation technique was the conventional technique with full sternotomy. And then after the novel devices with the third generation were available, the standard procedure was recommended, and some centers try to find new ways. Like in Hannover, where Professor Strüber and together with Professor Schmitto developed a new novel minimized approach with upper hemisternotomy combined with the anterolateral thoracotomy. And this is called the Hannover approach. The advantages of this approach are, in our experience, less trauma, less bleeding, and less right heart failure, because there is a no-touch technique. You needn't lift the heart. There's no kinking of the right ventricular outflow tract or the right coronary artery. There are no mechanical irritations which provokes arrhythmias, and the pericardium remains closed. So we made our homework, and we compared our patient group. We compared the conventional technique with the minimal invasive technique, and the distribution of the patient group was balanced, as you see. And as a result, it is not surprising, the ICU stay were lower in the minimal invasive group. Like also the right heart failure, bleeding, requiring surgery, and all the things we mentioned before were in the minimal invasive group less. So if we look at the survival rates, the two groups, there's also the advantage at the minimal invasive group with 89.4% against 82.6% in the conventional group. And this was the patient group with Intermex 3 to 6 profile. And when we look at the Intermex 1 profile, the differences are more evident between the two groups. And so we can say we made our experience. So in the moment we perform 85% of our LVAD implantations minimally invasive. So let us come now to the case I want to present you. It was a 57-year-old male patient. He was employed, he was in good exercise capacity, so every day he drove to his work 20 kilometers and in the afternoon 20 kilometers back by e-bike. So he was really in a good shape, and there were no important previous illness and no medication. So on 27 on July last year, he came to his primary care physician with high fever infection, nausea, vomiting, upper abdominal pain, and non-specific gastrointestinal disorders. So after 4 days sustained clinical symptoms, the general physician admitted him to the hospital in his county hospital, and there the patient was at admission in a reduced general condition with no fever. He has low blood pressure, low heart rate. In the ECG, you saw ST elevations on the posterior wall and the AV block 3rd degree. So they went in the cath lab and they implanted a temporary pacemaker lead. And in the diagnostic catheter, they could exclude coronary heart disease, but they saw a severe left ventricular heart failure with an ejection fraction at 15%. So after this, there was a hemodynamic deterioration and a transfer to the ICU with catecholamine therapy and anticongestic therapy. And then they phoned to to the Hannover Medical School, to the Department of Cardiology, and asked for transfer the patient to the ICU in the Hannover Medical School. So at admission to the Hannover Medical School, the patient was awake, not intubated. He was responsive and oriented. He was treated with catecholamines, so it was an Intermax profile 3 to 2. And in the ECG, you still saw the AV block 3 degree, but the heart rate was 118 because of the Dogan rapid ventricular escape beat with the right bundle branch block configuration. So here you see the laboratory test, and the CRP was high. The heart enzymes were high with an MB of 300 units per liter, and the troponin was very high with 6,000 microgram per liter, and the NT-proBNP was extremely raised to 35,000 microgram per liter. So this was a chest ray. There was a pulmonary congestion on this time. And in the echocardiography, you see a ballooned left ventricle and left ventricular dysfunction, the right ventricular dysfunction, and even the septum was not moving at all. So they went to the cath lab again. They put sampled some biopsies because of the strong suspicion of acute myocarditis. And then they put in the implantation, the impeller CP with a 3.1 liter support. After this, they have to intubate the patient because of the respiratory problems. So on the 2nd August of 2016, there was an initial stabilization of the hemodynamics. They admitted levosimendan at next point, and there was an increasing oliguria. In the evening, the patient gets some VTs. They were handled with amiodarone and with cardioversion. And in the night, the patient get an initiating right heart failure with loss of pulsatility, increasing need of catecholamines, and unstable rhythm. So the next day, they called us, and we, because of the progression of the right heart failure, we implanted a VA ECMO. So the patient had now a VA ECMO and a running impeller. So at that time, the catecholamines could be reduced, and there was an improving diuresis and a metabolic correction. And we have to reduce the impeller because there was several suction events, so that we put it on P4, and the support was now 1.8 liter. And the heart rhythm there was still an AV block 3rd degree and sustained VTs under amiodarone. So the next day, it was the 1st of August 2016, there was stable impeller and ECMO function, but there was no possibility to wean the patient. and everything was stable. The kidneys were stable with a stable diuresis, and so we shifted the co from the eyes, we say. And but we decide in our heart team with the cardiologist and with the cardiac surgeons, we decided how to step further. So, and we decided to put in an LVAD or a BVAD, or maybe a total artificial heart, we don't know at this point. And we make a family consultation about the bad prognosis. And then in the evening, we get the message of the biopsy results. So we send our biopsies to a special laboratory in Berlin to Professor Schultheis, because they are very specialized on myocarditis. And there we have the diagnosis. I will translate it. It was an acute, severe giant cell myocarditis with a very bad prognosis. And they recommended to us immediately immune suppressive therapy. So this we planned the operation for the next day, and before he get his immunosuppressive therapy with cyclosporine, Cellcept, and cortisone, and in addition to this with an anti-infective therapy with daptomycin, meropenem, and posaconazole. And then the next day we performed the operation. A minimal invasive LVAD implantation with the HVAD hardware, and simultaneous percutaneous implantation of a right heart bypass. We explanted the VA ECMO and the impeller. So shortly to the right heart bypass, we performed it through the vena jugularis, as a colleague told here, with the Swan-Ganz catheter. We put in a wire. And then over the smooth wire, we put in a special sheet that goes to the PA. And over this sheet, we put a stiff wire. And over this stiff wire, we put then the Medtronic 15 French Venous Biomedicus cannula. So, and then we first, because of the respiratory failure, we first put him on ECLS. And so it was a right heart bypass with LVAD support. So at the same day, admission to the ICU, the LVAD flow was 4.3 to 4.5 liters. The right heart bypass nearly the same, between 4 and 5 or 4 and 4.5 liters. Suprarenal and adrenal a little bit, and the central venous saturation was good, and the CO was also good. At progression week 1, the hemodynamic didn't change. It changed a little bit because we could extubate the patient and we could reduce the catecholamines. The measured LV ejection fraction was 10%, and we sometimes had to use dialysis for the kidneys. And then we put out the oxygenator from the right heart bypass, so it works like a RVAD in the moment with a Centrimac pump. And we still wait. So next week, then same flow on the LVAD and the right heart bypass. Then we could reduce the catecholamines, the kidneys recovered, there was adequate diuresis, and the neurological status was good. It was awake, responsive, and slightly orientated. So then we weaned day after day the right heart bypass, and 3 weeks after the operation we could put out the right heart bypass, we could explant it. And the hospital discharge was in the 4th of October, so nearly 2 months after operation. And then after 3 months, we controlled everything, and the left ventricular ejection fraction was at 20%, and there was only a slightly restricted right heart pump function. So this was a patient when he visited us after his second examination, and I know some institutes who put in such a giant cell myocarditis a total artificial heart. So I think this man was a very lucky man that the right ventricle recovered. And as a conclusion, I can say the minimally invasive technique. In our department, every uncomplicated case gets a minimally invasive procedure. So I think 85% of our LVAD implantations are minimally invasive. So especially when there is a right heart dysfunction or a biventricular impairment with preoperative support of ECMO and impeller. In redo procedures, it is easier to perform the minimal invasive technique because you needn't to dissect all the adhesions. And the same when you make an LVAD exchange, you only open the anterolateral thoracotomy and then you can change the LVAD. May be a problem when the thrombus is in the outflow graft or when the outflow graft is also infected, but these are only special cases. Also special anatomical occurrences, as you see the photos below, you see a patient with an agenesia of the left lung, so the right lung shifted the heart to the left side, and we performed the operation from the left side. And sometimes device dependent, so we have some problems with the HeartMate 3 sewing ring. It's a little bit big and not, you can make it, but it is possible, and we performed it also, the minimal invasive technique with the HeartMate 3, but it's not as comfortable as with the HVAD. So for the conventional technique, only the concomitant procedures with tricuspid valve replacement or reconstruction and a simultaneous CABG procedure is for conventional technique, or a VAD, RVAD, or total artificial heart, or in infants, and maybe sometimes also, as I mentioned, device dependent. So, excuse me, but thank you for your attention.
It's a pleasure for me to announce Christian Schlensack from Tübingen to